Hello. Hello.
Hello, ma'am. Good evening, ma'am.
How are you?
I'm good, ma'am. How are you?
So I just wanted, there's some echo coming.
Yeah. I'll just check.
I'll just check my video and my slide.
Sure.
So you can see that, right?
Yeah. You can just use full screen, ma'am. Yeah. Yeah, it's coming, ma'am.
Okay.
Yeah.
Okay. And I also wanted to check my video.
Sure, ma'am.
Good evening, madam.
Hi. So just check whether you can hear the.
Yes, madam. Good evening. I am Dr. Vasanta Kumari Andi.
So could you hear the sound?
Yes, sir. Yes, madam.
Okay, good. So should I unshare? You have to put some slide first.
Pardon me?
Are you going to put any slides?
Yes, ma'am. I want to just introduce. I have 2 or 3 slides.
Okay.
I'll just put them. Then I'll hand over it to you, ma'am.
Okay. Thank you. Thank you. I'm so honored to be invited to this real important session. Yeah.
We have got YouTube link also for this webinar, madam.
Yes, I saw that. Thank you so much. I think
Just now it is done.
Thanks.
Because I am expecting more, so I don't want people to be disappointed.
Yeah, I have put for all my national, international students
Okay.
to our societies. So I hope,
Yeah.
more people will benefit.
మన ఇద్దరం ఒక రూమ్ లో ఉండలేం.
مين انتزاعات المين؟
يوم التفتيش
آه.
بنت جوه قاعده في اللوكر سايبه الراجل عمال يتكلم مع مدونة البنت العيله وعماله تعك في الكلام.
امال مين دي؟
International meeting. International or national level meeting.
Good evening, Madam Subhadra, Madam. Good evening.
Good evening, sir. Thank
Good
you.
evening, all.
For your kind
Good evening,
invitation.
madam.
It's always lovely to
Thank
see you.
Thank you so much for accepting our invitation with despite your busy schedule. So thank you so much.
Pleasure is all mine. I'm getting the stage. Thank you.
Doctor Sahab, good evening.
Good evening. Good evening. Yadav sir. Good evening, Subhadra madam.
Sir, very happy to see you, sir. Please.
Namaste,
Pleasure is
sir.
on me, sir. Pleasure is on me, sir.
Sir, sir.
Good evening, Sheshu.
Good evening, madam. Good evening.
5 more minutes to start.
5 more minutes.
Yeah.
And I'd like to take few minutes again, madam.
Yes.
Hello.
Yeah.
We'll wait for 4 minutes, man, for 5 minutes. 5 to 8.
5 minutes. 5 minutes.
5 minutes. 3 more minutes.
అక్కడ ఓపెన్ చేసి తర్వాత
Madam Vasantu Madam.
Yes, sir. Good evening.
Madam, I think we can start. It's almost 8. We can start. It will take some time for introduction.
చేద్దామంటారా? ఓకే
Chedam, madam.
ఓకే
Now just 1 minute to go.
Yeah. Okay. Namaste and good evening to you all. I am Dr. Vasanta Kumari, Chairman, Scientific Committee, IMA Telangana. On behalf of IMA Telangana, I cordially welcome you all for Wednesday's webinar on Retinopathy of Prematurity, ROP screening in neonates by the eminent speaker Dr. Subhadra Jalali, Madam from LV Prasad Eye Institute, Hyderabad. At the outset, I would like to thank you, Madam, for accepting our request. I now request Dr. Sheshu Madhav, President, Pediatric Association of Telangana State, to inaugurate the session. Over to you, Dr. Sheshu Madhav.
Good evening, Dr. Vasanta Kumari Madam, Chairman, IMA Telangana Scientific Committee. So it is my pleasure inaugurating today this webinar on retinopathy of prematurity, ROP screening by none other than Dr. Subhadra Jalali Madam, and moderating by Dr. Yadav sir. So as we all know, so nowadays the primaries, very tiny neonates, 28 weekers, 30 weekers were coming out in this SNCUs and with all the efforts of the pediatricians and neonatologists. But that ROP screening has become a must, and wherein with the minimal interventions, we are making more this baby's life more beautiful. So now I think we'll be hearing more from the pioneer of ROP screening, Dr. Subhadra Jalali Madam, about how we go about this. So I officially inaugurate this webinar. Thank you, Madam. Thank you all.
Thank you, Dr. Sheshu. I request Dr. Pranusha to be the chairperson. Dr. Pranusha is eye specialist and retina and uvea specialist from Netra Eye Clinic, Anurag Hospital, Nalgonda. She is our Nilgiri IMA member. I welcome Dr. Pranusha to take over the session. And I also thank Dr. Pranusha for chairing the session. I also thank Dr. Yadav sir for moderating the session. Over to you, Dr. Pranusha. Over to you.
Thank you, ma'am. It's my pleasure to be the part of this meeting.
Yes, Pranusha.
Not audible, doctor. Some network issues. Not audible.
Her face is frozen, so I think it will just take little time. Yeah, she's there.
Yeah, I'm there.
Pranusha.
Just a second.
Yes, please.
Thank you, ma'am. And sorry for the delay. It's a small disturbance in the technical issue, and I'm very glad to be the part of this meeting. This is Dr. Pranusha, ma'am. So today we are here to, ma'am, all of the webinar members are excited to listen to your lecture. So we are very happy to introduce you. It is none other than but an eminent personality who is a pioneer in ROP, Dr. Subhadra Jalali. She has done her MBBS from Jammu University and her post-graduation from PGI Chandigarh. She has also done a comprehensive fellowship in retina at LVPI and fellowship training at National Eye Institute, an esteemed university in ocular genetics and electrophysiology, fellowship program in ROP and pediatric retinal diseases at William Beaumont Hospital, Royal Oak, Michigan. And Madam has several national, international awards. She has also got International Talent Search Award. She achieved award by AO Ophthalmology, AIOSP Shivareddy International Award, IJO Platinum Award, Mother Teresa Award, Member National Task Force on ROP, Ministry of Health, Government of India, Eye Health Leadership Award by International Agency for Prevention of Blindness. Madam has got a very prestigious award, Sight Savers Grant, from setting up training centers and treatment for the control of childhood blindness in the field of ROP in Andhra Pradesh. Recently, she achieved a True Eye Health Hero Award by Queen Elizabeth Diamond Jubilee Trust. Currently, Dr. Subhadra Jalali is a director at Newborn Eye Health Alliance Neha Group of LVPI and also director of quality at LV Prasad Eye Institute Network. And she is the head clinical services at LVPI Kalamanji Reddy Complex. And she's currently as a chief consultant in vitreoretinal services, also in pediatric retinal disorders. Apart from this, Madam is a global ambassador to propagate the Indian culture. She's also a very, very good dancer and singer. And I also be happy to introduce our moderator for today's session, Dr. Damer Yadaya sir. He's currently working as a nodal officer and SNCU unit at Government General Hospital, Nalgonda. He's a great pediatrician and his interests are in early initiation of breastfeeding, in kangaroo mother care. Also, he
No problem. Can we? Thank you, Pranisha. Until we can start, I think introduction is enough. Thank you so much for your kind introduction. And Subhadra Jalali, madam, honestly, don't need any introduction. Her name goes synonymous with retinopathy of prematurity, and she's working more than 2.5 decades. And I know madam since almost 2 decades. And we have been regular touch since 2015. And with the baby of Mamata, am I audible, please?
Yes.
Yeah. Baby of Mamata, 650 grams in 2015. And we noticed that baby was having ROP. And we have contacted madam through one of our neonatologists, Dr. Srinivas Murki, that she is kind enough to come to Nalgonda. And she didn't know where Nalgonda was exactly. She came through a Google map and she performed laser at SNC Nalgonda. The baby was 45 days old and the weight was 530 grams. And that was the smallest baby to do ROP in any peripheral units or any SNCs in the country in 2016. And the baby is fine. Now she's 8 years, 9 years. She's going to school. She has 80% vision with correction and otherwise she's normal. So all of us know ROP is not a disease, it's a disorder. It's a preventable blindness. And it is a time to screen ROP in all the newborn care units. And madam is working since 2.5 decades over that. And I think it's over to madam to start the session. Thank you so much for accepting your invitation, ma'am. Please.
Thank you so
Over to
much.
Dr. Subhadra Jalali.
Thanks a lot. I hope everybody can hear me. So I'm a movie
Yes.
buff. I just love movies. I wish I didn't have to do ROP stage 5 surgeries late in the night and I could go and watch night shows. So let us start with a nice movie. I hope that, the sound works and everybody can see.
नॉर्मली सब लोगों को एक बच्चा 2 बच्चा होता, बट व्हेन आई एम द 3rd month प्रेग्नेंट, उसी टाइम में पता हुआ मेरे को मैं ट्रिपल को క్యారీ హెరా बोल के ప్రాబ్లం లేదు, అంత హ్యాపీగానే ఓకే రన్ అవుతుంది.
At 28th week, they are born premature. We have spent 2 months in NICU. Babies have been kept on ventilator, CPAP, oxygen. It's been quite a difficult journey for us.
नॉर्मली प्रीमेच्योर बेबीज को कुछ इश्यूज होता बोल के वो पता है, बट स्पेसिफिकली ROP एंड पैरा टेस्ट वो इश्यू के साथ पता नहीं मेरे को. व्हेन वी आर इन KMC ट्रेनिंग, दैट टाइम दे सेड पैरा टेस्ट एंड ROP टेस्ट होता बोल के खाली इंफॉर्मेशन दिया, बट कब करना, कैसे करना, किधर करना, वो मेन ड्रॉबैक इज रूरल एरिया, करेक्ट गाइडेंस नहीं.
One day I was going through internet and in YouTube I saw some ROP video.
में सुभद्रा मैडम का वीडियो आया. एक दिन पहले मैं मैडम का वीडियो देखा. नेक्स्ट दिन मैं ROP टेस्टिंग को गई तो डॉक्टर इमरजेंसी स्पेसिफिकली इंस्टीट्यूट का नाम LV प्रसाद आई इंस्टीट्यूट में सुभद्रा मैडम होता, वो मैडम ने करना. ये सिचुएशन तो सीरियस हो गया, ज्यादा दिन लेट हो गया.
We kept our faith in Subhadra madam and completely cooperated with madam.
मैडम ट्रीटमेंट करने के बाद ज्यादा ఇంప్రూవ్మెంట్ हो गया. లాస్ట్ గా నేను ఏం చెప్పాలనుకుంటున్నానంటే, ప్రతి హాస్పిటల్లో ప్రతి పీడియాట్రిషియన్ ప్రతి ప్రీ బోర్న్ బేబీ ఆర్ లో వెయిట్ బేబీకి కంపల్సరీగా టెస్ట్ల గురించి అవేర్నెస్, మెయిన్ ROP అండ్ బైరా టెస్ట్ వీటి గురించి అవేర్నెస్ ఇవ్వాలి అని చెప్పేసి సజెషన్. దాని వాళ్ళు అవేర్నెస్ ఇస్తే ఇన్ని సిచ్యువేషన్స్ రావు, ఇనిషియల్ లోనే చాలా వరకు క్లియర్ చేయొచ్చు.
So I hope that the lady's message is clear and loud. It would have been so tragic if all the 3 beautiful babies would have been blind, and that was a real possibility. And, they just came in nick of time, another 2-3 days, and we wouldn't have been able to save those eyes. So I will start by, talking something about ROP. And then I hope there's little time to talk something beyond ROP also. For the neonatologists and pediatricians. So I'm thankful to the IMA and to Madam for having me here, and thank you again everyone for joining in. I hope my slides are visible.
Yes, madam.
Okay. So I'm going to talk about some risk factors and mitigation. How can we reduce the incidence? How can we manage them so that they don't become blind? I have no financial disclosures. My institute gets grants from various agencies to run ROP programs. So, these are small citizens. Preterm babies are the tiniest citizens of our country. The youngest baby I have treated for ROP was 325 grams in Rainbow Hospital. Maybe that is the youngest baby surviving in the country. So how much effort, time, resources we should give to these youngest citizens of our country? Sometimes the resources are taken up by tuberculosis program or HIV or maternal health and so many other programs. And, these tiny babies whose eyes are shut, there's no advocate for them. They cannot express that, my vision is losing. So I always say that, for pediatricians and even for parents, if the child has some heart problem, some, kidney problem, feeding problem, GI problem, lungs problem, all of that will get manifest in vomiting, poor weight gain, cyanosis, breathing problem. So everybody comes to know that baby is unwell. But what about the eyes? If there is a problem, especially when there's a problem like in the retina or cataract, these are all silent diseases. There's absolutely no sign till they become blind, as you see in this picture on the right side. And that is what the ROP blind children will look like. Their eyes will be white. They'll be watering all the time. They'll be screaming in pain for most of their life. And they keep on rubbing their eyes. So it's a very miserable situation. And they were not born blind. They were not born blind. They were absolutely okay for their age. So ROP is a disease of middle income countries where we are aspiring, we are having a lot of newborns, we are saving a lot of newborns now, and we are taking access to assisted fertilization techniques. We have NICUs, SCNUs. So really, it's an epidemic which has come to our country in last 25 years. Before that, there was no ROP. So just to reiterate that the first incubators in the world was set up in Boston Children's Hospital in 1941. And the first ROP was diagnosed and reported from Boston Children's Hospital in 1942. So it's very clear that for last 60, 70 years, we are aware that the moment you start saving babies, there's NICU care, there's hospital care, we will get blindness. So if somebody says that, my babies don't get ROP, it's a myth. It will always come. So this is just some old data. I don't have to tell this data to all of you. You're doing great job. My child was preterm. Dr. Suresh Surapnani saved him 28 weeks, 1.3 kg. 25 days I was in NICU. I know how much effort goes by the nursing staff, by the hospital admin, by the neonatologist, pediatrician, and the parents working together to save these newborns. And we're very proud that our newborn mortality rate has gone down so much, especially in our region. And this is old data now. We are much better. And millions of these babies were dying. So we were not seeing this ROP. But the moment we have started surviving them, the ROP has come. So ROP is, a disease that we are tackling in terms of saving newborns, because this is part of the sustainable development goals that we want to be a developed country. We want to save these newborns. But ROP is a sort of iatrogenic disease. It's not an ancient disease. The smallest survivors are at highest risk, but everybody is at risk. And of course, the suboptimal care also adds to that risk. So you can see here the children, they may be surviving, but the type of care we are giving in terms of oxygen, hypothermia management of their glucose and their hypoglycemia. So that all adds up to their morbidities, although they survive. So the babies that we have in our country, as most of you know, they can be, in a very swanky, getting the best care, better than many other countries, or they could just be having an average care, where they just survive. So we have the whole spectrum of all the types of care across our thing. So this is the 10,000th baby that we saw in our unit. She's born too soon, but as I said, not born blind, so pretty, but you can see that her eyes are white when she came to us, at 3 months of age. She was from a coastal part of the country in a government SCNU, where she was, there for 25 days. And so many national and international experts have helped our country to set up these beautiful SCNUs, so much of staff, everything is happening. But somehow the baby did not get the eye care, and then she became blind. And, we have struggled to give her back a vision. Now, after multiple surgeries, she has little vision, but really she is, legally blind. So this is the India growth story. You can see where I come from, Hyderabad city, and this is a beautiful city with a lot of ancient heritage, more than 400-500 years old. And then we have this swanky Hyderabad, which is a new city, new world. And inside that, you can see when I came here in 91, IV Prasad started in 87. You can see the data on the right side. We had no ROP. There's no ROP in our database till 95. And 94, 95, we started seeing 3, 4, 5 babies. We have, records of all the patients, prospective records. So we didn't have any ROP. And you can see it matches what was happening in one of the tertiary hospitals, that the preterm births were increasing. They were less than 5% initially. Now I think 20 to 25% of live births in all the tertiary centers are premature. And of course, the death was decreasing. And that sets the stage, what we call as the ROP epidemic, which will happen when the neonatal mortality will reduce and the premature births will increase. So we have a database. It is called Indian Twin Cities ROP Study, IT Crops. We are very proud. We have published 15 reports of this study, and it is an ongoing study, has more than 25,000 babies now. And we have all the data, how the story unfolded, what happened, how many babies survived. And so you can see that in 1998, that's the arrow where I came back from my training in ROP from US. And rapidly our city was geared up to take care of these mushrooming SNCUs and the babies. And what we can see is, we have the database from LV Prasad Institute. This is just one of the data, just to say that in childhood blindness, we just looked at between 2000 to 2013, over 13-year period, what is happening to our children, childhood blindness. So you can see here vitamin A deficiency, which used to be a major cause of blindness in our country. We've overcome that. Only in some few areas we see vitamin A deficiency, keratomalacia. Otherwise, all pediatricians, nurses, parents, they all know about vitamin A deficiency. People are getting that. So we are seeing very rarely. Congenital cataracts and congenital glaucoma, which are inherited disorders, they have not changed much. Just the population increases there and they remain same. But look at the preterm babies, almost a 10-fold increase in 10 years. And the number of babies that we are handling. And this is 2013. Now every year, more than 1,500 babies just at one center. We recently crossed 1 lakh preterm babies in our network of 4 hospitals. You can see some of the data here. And what is more interesting is that although the number of babies has increased, the number of surgeries has increased, but also previously 15% babies were coming from smaller towns and district in 2000 and 2003. But now in 2014, 15 and much more now, more than 1/3 of the babies are coming from small towns, semi-urban towns, names where I had never heard those names. From Purulia, from Bulandshahr, from places previously they used to come from Mumbai, Delhi, Calcutta, maybe Aurangabad, big cities, but now they're coming from smaller towns, and that is the disease has shifted from major cities to all the towns and sub-districts and districts where SCNU have been set up. And so you can see here the number of surgeries also. So the complexity of cases has also increased. We were doing few surgeries. Now I think we are the largest surgical unit in the whole country and maybe in Southeast Asia, maybe in the world, because we are really operating at least 30 to 35 babies every week in our hospital. And this used to be less than 1 in 2-3 months. Really, the complexity has also increased. So what is ROP? ROP is basically a vasoproliferative disorder. You are seeing this is what a normal newborn would be born with. They have, retinal vessels, and if they are 30 weeks or 31 weeks, the vessels have grown only from the optic nerve to the mid-periphery, and then they are still growing, and suddenly the baby is born. So normally these vessels will slowly grow. Normal vessels are dichotomously branching. This is some modulation which happens in the retina. This is not ROP. These are all pictures of normal in preterm babies. There's no ROP, and slowly the retina will get vascularized till it reaches the end. So what we need to do is to look at the retina, look at the vessels, follow them and follow these babies every 2 to 3 weeks and make sure that the vessels have reached the end, after which the risk of ROP doesn't happen. So this happens in 70 to 80% of babies, that the retina is not vascularized at birth. Slowly it will vascularize and everything will be fine. And then we can release them from screening. But in some babies, what happens is because of various factors, both antenatal, maternal, and postnatal factors, labor room factors. So there are multiple factors which cause this. And what we see is that the vessels stop growing. So they dichotomously branch, but they stop growing. So what will happen? It will form a ridge because it has just stopped growing. So they are multiplying rapidly, but they're not moving forward. And that is what we call as ROP. And it can manifest as mild disease called stage 1 or more thicker disease called stage 2. And then it forms new vessels. Once it forms new vessels, which are stage 3, it becomes highly risky for detachment, because now these vessels start bleeding and they can pull the retina and the retina can detach, and ultimately it goes into stage 5. So these are stage 1, 2, 3. So ROP also we describe something called plus disease. So you can see here normal vessels are dichotomously branching, thin, few. And then what happens if there is, disturbance of the chemicals in the eye? Most of that is VEGF, vascular endothelial growth factor, but others also, they get upregulated. And this is what happens, what we call as plus. So plus is nothing but dilatation, tortuosity of the vessel, the pupil doesn't dilate. It can become very severe. And this is the stage where we say we have to treat. So there is no difficulty in, for the doctors who are trained to diagnose. If we can have pictures, of course, pictures speak 1,000 words, people can diagnose. So there's no difficulty in training anybody to look at these pictures. And in future, we are getting AI on these pictures so that the automated system will tell is there danger signals or not. But currently also, if people are careful, they can see that the veins are enlarged and there's tortuosity. And so we say that, things are bad and this patient needs treatment. Somebody like this thin vessels, they don't need treatment. So, not needing treatment and those needing treatment, we call that as the plus disease, which means disease is active, it is worsening. So you can see here, I have drawn the timeline. The ROP is the best disease in the whole of medicine to screen. And this is from Cochrane review. They have shown that the cost effectivity, the DALIs, which is like, how much benefit is there of screening, is highest for ROP, because the child, when they come to the hospital, they don't have any disease. It's very rare for medical profession to get patients, the child has so many morbidities, but the retina is healthy at birth. It's completely normal for its age. There is no pathology. And then, in few weeks, it will be mature, it has to grow, but then something happens. And after 2-3 weeks, which usually is 20 to 30 days, that's why we have said the ROP starts. So we have a window. And then it remains like that for another 2 weeks or so. And then slowly, by 6 to 7 weeks of birth, the stage 4B, that is macula, starts detaching. And by 3 months, the child presents with leukocoria and nystagmus and eye pressing. And that is the time when everybody starts noticing the child is not having eye contact. But that is the end. The fire has already destroyed the retina. There is no treatment. We do surgery, but that gives only some light perception. And some of them can, as I said, get into very severe, painful blind eyes because of secondary glaucoma. So, so the natural history is so well known. We know exactly what is happening. We can see what is happening and we can intervene at the appropriate time. So the randomized controlled trials done in 1980s, which is like almost 40 years ago, all the proof is there, all the evidence-based medicine for this disease is there, which cases to treat, how to treat. And you can see here, once bleeding starts, we do laser, everything goes away. It's just like you have put out the fire and the child can enjoy good vision for whole life. So this baby again comes back and asks us who stole my vision in 2017, when the natural history is so well known for the last 40 years. So we already have all the data, all the publications. So everything is there in journals. Why it has not reached the bedside of the babies along with the beds? The beds have reached this, survival is there, but the safety net of eye screening is not there in most of the Southeast Asian countries, including our country. Whereas, today in the West, you cannot set up an NICU or a childcare center without an eye specialist coming there every week. It is illegal. They will shut it down. They don't want to save babies who will then land into blindness. So this is what we need, that, any place which has a center which is taking care of premature babies needs to have an eye care program set up, just like the vaccination program is set up. So everything has to be set up there. So we are very proud that, all the pediatricians, neonatologists, gynecologists, nursing people, Nursing College of India, the Nursing Council of India, and administrators, Government of India, so many people, they got together under the leadership of Dr. Arun Singh and Dr. Professor Rajvardhan Azad from All Institute. And we prepared this universal eye screening and ROP guidelines, RBSK guidelines now. So this is the guideline that, will set the stage for India. For any legal things, for anything, this document is written in very simple language. It is freely available on the net. If you go to RBSK website, you can download this PDF. All the details given in very simple language for healthcare workers. what to do, who has to do, how it has to be done. So easy to remember is the 2-3-4 rule. So 2 kg and 34 weeks. So anybody less than 35, that is 34 weeks. So 2-3-4. Don't get confused. Don't get confused with American guidelines, UK guidelines. It's easy to remember. 2-3-4. 2 kg, 34 weeks. So now the NNF also has agreed to the same guidelines. So now we have previously there was some discrepancy, but now everybody is on board. So for India, it is 2-3-4. First screening at 30 days. If they are smaller, do it at 20 days. If they are preterms whose gestational age is not well known, then please get it screened. Don't worry, like, it's 2.1 kg, so why should I get screened? Or, mother doesn't remember the dates, so why should we screen? Just get that screen. Even now, WHO has come with universal guidelines, which I will talk later. But at least for ROP, don't hesitate to send some baby for screening, because it is so, life-changing situation. So if there's an abandoned baby, your parents don't remember the date, but you think it's preterm, just get it screened. And don't worry whether oxygen was given, not given. The ROP doesn't happen due to oxygen. The ROP happens due to prematurity itself, whether baby has oxygen or not. Oxygen can worsen the disease. Mismanaged oxygen can lead to more severe disease, but the disease itself, now more and more data coming that it is antenatal factors, it is intrauterine factors, and then the postnatal factors. So even babies who apparently have no risk factor, they can get blinding ROP. So what do we do for screening? Nothing. We just have to dilate and do a fundoscopy. All of us have learned fundoscopy in our, MBBS, MD. We are doing fundoscopy for neurology, for, raised intracranial pressure, whatever. So here, yes, it's little challenging, but it's not all that bad. Actually, these children are quite comfortable. There are a lot of ways to do the fundoscopy, cameras, indirect ophthalmoscopy. So ultimately, we just have to look at the retina, do a fundoscopy, and give the treatment which is effective and evidence-based. So why India has different criteria here, you can see this was published by Claire Gilbert, the pioneer of ROP in the world, where she showed that children who had, bad ROP in developed countries fell between 31 weeks and 1500 grams. And most of their screening criteria are this. Now, the same thing we see in high-end, centers in our country. Rainbow Hospital, Fernandez Hospital, AIMS, PGI, they see the same spectrum which you are seeing there. High-end people are coming, rural ladies are not coming, anemic mothers are not coming, poor antenatal care children are not coming. So they will see, something like a scenario of the high-end in the world. But we all belong to this category. We belong to what is called middle income countries. So you can see here India, Delhi, India, Hyderabad, India, Madras. That time it was called Madras. Now it's Chennai. Our data is here, mixed with Lithuania, Peru, Vietnam, Argentina, Brazil. So all the middle income countries, what we see is that bigger babies, more than 31 weeks. So you can see 34, 35 weekers, and more than 2 kg, even 2.5, 3 kg babies are getting ROP blindness. So this is only the severe ROP. We are not even talking of the mild ROP. These are babies who were either blind or really had advanced disease to cause treatment. So what we see is that, our criteria are going to be larger babies, bigger babies, and more number of babies. So you can see, what ROP they will see. They're not even producing babies. Who is producing maximum babies in the world? India, 30 million children, highest in the world. We are #1 country. So who is going to teach about ROP? Who is going to teach about child care? Who is going to teach about neonatology? We should be teaching the world, not world teaching us how to care for these newborn. No, we have huge numbers. You can see that here. So then I'm not going to details. Yes, there are safe drops to be dilated. Adult drops should not be used. Atropine should not be used. There's a, now it is ready-made available as 2.5% phenylephrine and 1% tropicamide. We pushed the companies to make it. Previously, they were making 5%. So if 5% is available, it has to be diluted. But now in the market, 2.5% also available. And we put the drops 2 or 3 times, watch the hypoglycemia, watch the pulse rate, and, make sure baby is warm. And in 15 minutes, the pupils dilate. You can see they dilate really well. And then we can do the fundoscopy for these babies. So there is very low risk of screening. Even babies on ventilators, even babies who are sick, even babies who are having any problems, they can be safely dilated, and a good examiner will hardly take 5 minutes to examine the babies, at least to take a picture of the posterior pole or to take a peek into the eye If it is bad, right on the bedside in the NICU, we have just published our data of large number of babies. Safely, we can give the injection. Even laser we can do. I have done lasers on babies on ventilators. There's no issue. They are in well-controlled environment. It can be done. So why we are pushing all this? Again, we have published, this was our, IT crops database report. In our city, what we found is that when we started, a lot of blind children were coming. Within a couple of years, actually within 2 years of our starting the screening program for the whole city of Hyderabad, Secunderabad, and this was the first such citywide program in our whole country, we found that, immediately we could bring down the blindness and increase the number of babies who could be treated. Previous to that, most of the babies would come, they were blind. So the other thing to understand is there's something called aggressive ROP. The new terminology is aggressive ROP, AROP. Previously it was called aggressive posterior ROP. Now this AROP, previously called Rushdie, also is a condition which is very fulminant. It will lead to detachment and blindness within a week or two. I already showed the timeline that usually there's 2, 3, 4, 5 weeks before, it goes out of hand. But here AROP, which is more seen in tiny babies, more seen in unblended oxygen given, more seen in anemic mothers, babies, and very babies who are not gaining weight. So, or they have pneumonia, they have severe lung problems. So these babies, they get something called AROP, and this can be missed because it may not show those stages. So you really need a trained person to pick this up, and this needs treatment within 24 hours. So we can't wait. And these children are 90% of these are anemic children. So they need transfusion, they need injection, they need aggressive laser, and we can win the game. Otherwise, this is a group of babies who does very poorly. So you can see here, so what we try to teach the students is the pattern. So normal vessel should be dichotomously branching. In AROP, what happens? They start looping. They start bunching up. They start, just changing that pattern. You can see here. So this retina, it is showing the vessels are dichotomously branching. That means in this 26, 27 week age, they were normal. And then something happened. Maybe baby got sepsis, maybe it went on ventilator, maybe it got, a bad infection, or maybe it suddenly desaturated. And you can see now, by the time they reached here, the vessel started, forming loops. So that means that now this is a danger state and we need to pick it up and treat it. So how we treat, if we are treating with laser, so this is the baby has come at 40 days. You can see big blood clots. Again, we sometimes show these pictures to parents because sometimes they are not convinced that there's something because from outside eyes look normal. So even if it is not of their baby, but we just show these pictures that this is what is ROP. When any parent sees the blood, they understand what we are talking about. So there is no issue of parents not complying with treatment. Once we, just put up a chart and 1 or 2 pictures we show. And after laser, you can see dramatically within 3 or 4 days, the disease start regressing. But we have to watch, just like a fire. If we put out the fire, we always watch, is it smoldering? So it can smolder. So this baby, upper part of retina is okay, lower part still bleeding. So we have to add laser. So sometimes we have to do 2 or 3 sittings of laser because the disease has not gone. So we have to make sure that trained people do this laser. It requires good skills. And they follow up every 2, 3 days, 5 days, 7 days. Very closely we have to follow. And so that becomes an issue when people are coming from a distance. But we have to follow them when they are in that hot period and make sure the disease has quietened. Now, what are the risk reduction strategies? So fortunately for us, ROP is something which can be controlled to some extent by, good quality neonatal care. And here the nurses are the major player. So we know that, if the mothers are, not anemic pre-op, before their pregnancy, that is taken care of. Antenatal steroids, which the now obstetric and health ministry of India has made mandatory. It's still not percolated everywhere. But yes, antenatal steroids improve the lung condition. They also improve the ROP. Then sepsis control, again, we all know that in our country, sepsis, hospital-acquired sepsis is a huge problem. Hand washing, barrier nursing. These are very important to be trained and followed and checked, and quality checks done that these are followed. And, then we can bring down the ROP. Or, of course, the morbidity and mortality will also come down. Now, oxygen has been talked about in ROP for ages. We know that, uncontrolled, unblended oxygen is very toxic to the retinal vessels. It is also toxic to the lung vessels. So babies will go into a cycle of chronic lung disease and ROP. And so what we need is, good blenders, low cost blenders. They're not available everywhere, one for each baby. And then having the blenders is not enough, because the nurses have to be educated how to monitor the oxygen, what are the target oxygen saturations to be kept. So all the NNF guidelines are there. Everybody should try to follow. But at least, so I know that the number of nurses is less than the number of babies. I went to some hospitals, big hospital, government hospitals, and there are 500 babies, 600 babies, 15, 20 nurses. They cannot handle all babies. It's going to take ages till, our nursing care reaches the level that we want to see in our large units. So, but at least what we can do is that, if the ROP screening starts early, let's say 2 weeks, and the doctor goes around and sees babies, they can identify those 7, 8, 10 babies who are at real risk, who have a zone 1 retina, who have ROP. So at least those few can be put on pulse oximeter, they can be given good care, and then we can, slowly bring them out of a potentially devastating situation. Even if we can't do great nursing for all the babies all the time, but at least the vulnerable babies, we do identify, we tell the doctor and the nursing staff that at least monitor this one baby, because this baby is, really worsening. So those strategies can be done. Then nutrition and weight gain. So data has shown that poor weight gain is a big marker of ROP. Good evidence is there from the West. Even our data we have not published, but in our clinic we see from a far distance we can identify, this baby will have ROP even before touching, like, like in astrology we can predict, because we can see that baby is 2 months old, but it's still very tiny. So, proper nutrition in the SNN news from the mothers and other things. If the baby starts gaining weight, then they have less risk of ROP, and they respond better to treatment also. Now, we did a study with the Fernandez Hospital where we showed that for the same gestational age and the same birth weight, if the child was born to an anemic mother, their retina was much poor at birth, within 1 week of birth, than those who were born to healthy mothers. Now, this is very important, because this was the first time in the world that we said that, maternal health is influencing the retina of what that baby is born with. I'm sure it affects other things also. And now more and more data in last 20 years has come. This we published in 2006. And so, of course, after all this, we also have blood transfusion. So, for blood transfusion, there's a whole lecture, but from ROP point of view, what we have seen is, and we have just published the data, that if the child is anemic, while we are doing the ROP care, they really worsen. They don't respond to treatment at all. So while the guidelines for transfusion in neonatology and pediatrics is there, it doesn't take into account the ROP situation. So we are trying to build that evidence and data, and say that if during the ROP care, when we are giving injection, when we are giving laser, the baby has ROP, at that time we want at least hemoglobin of 10, like they should not be severe or moderately anemic. Also, a caution for large babies. So babies who are born to diabetic mothers will look large. They may be 2.5, 3 kg. Babies who have hydrocephalus, intestinal obstruction, renal disease. So these are large for gestational babies. They are at same risk, or actually more risk than these small babies. So just because they are big weight, we should not think that they'll not get ROP. We have so many children who have hydrocephalus, shunt surgery done, but no ROP screening done, and they are blind. So these babies must be screened, and they're at high risk also, even if they have, abnormal high weight, large weight. So how can we prevent ROP? There's a huge list of things, can we prevent premature births? I know we can't. Actually, the premature births, as I showed, is rapidly increasing, and it's going to increase. So that is going to happen. But there are, various things one could do, to monitor and prevent these premature births. And then I said the antenatal steroid, whatever is the recommended dosage. And then we come to the oxygen management. So the NNF is put out how much should be management. But from our point of view, mostly we want that there should not be fluctuation of oxygen. So what sometimes the nurses do, they are so worried about ROP that they will switch off the oxygen when they are feeding, because during feeding baby is apneic or desaturating, then they will put a nasal prong and give intermittent oxygen. This is the worst thing one can do for ROP point of view. Even if the oxygen is a little higher, but it is a blended oxygen and it is not fluctuating, that is better then switch on, switch off, because then the upregulation of these VEGF factors goes really high. Both in animal models it has seen, and we have also seen. The moment we start, putting target and making sure that it is not fluctuating, the ROP can be controlled if it is in the early stages. So education of nurses becomes very important here. So about the weight gain, I have already told. So I don't have to tell people here. Of course, we always, advocate breast milk feeds. If there are milk banks, that is also good. And then the kangaroo mother care, which reduces the sepsis and also improves the weight gain. So all these things are very critical, and every unit has to keep on moving towards these areas, so that not only the ROP and blindness becomes less and less, but also all other morbidities. Now, the pneumonia, chronic lung disease, again, as I said, make sure that, when the child has ROP, this I tell to all the ophthalmologists also, during ROP care, make sure, baby is not grunting. Baby doesn't have blocked nose. All this leads to hypoxia. So if they need nebulization, if they need some chest physiotherapy, if they need cleaning of the nose. So along with the pediatrician, we work with them, and we also tell the parents, and we talk to the pediatrician also, and we together make sure that these things are accounted for, especially for babies who have been discharged from the NICU. Because if we don't take care of this, the ROP keeps on worsening, because the immature lungs secrete a lot of VEGF, and that goes into the eyes and worsens. There's a huge connection between lungs and the eyes. So both things are very, very important, both from the VEGF point of view and anti-VEGF point of view. And anemia, I already said, this is very important. The other point is the education and counsel of parents that don't miss appointments. If they, in between, they get admitted somewhere because they may have some intercurrent infection, or they may have some hernia surgery, or something is happening because they have multiple comorbidities. We tell them, if you are admitted somewhere, you are not coming, inform us. We will come to you. We will send somebody there. But don't miss appointments, because, every visit is very, very critical. And sometimes it has happened that, we have written in the file, we have told the parents to come for follow-up. But unfortunately, the pediatrician told that, no, everything is okay. You don't have to go for follow-up. Don't do that. They need follow-up. Even if we write that things are doing okay, there is a protocol of how we have to release them for screening, how many times we have to follow, and everybody should follow. Again, the guidelines are there. So this is just to show, sometimes when we do the fundus photos, it may show some hemorrhages. These are normal vaginal delivery hemorrhages. They are not ROP. So how we differentiate normal birth trauma hemorrhages from ROP hemorrhages, that ROP hemorrhages always occur at the end of the vessels, primarily. So where the vascular and avascular retina is meeting, whereas the birth hemorrhages can occur, in between. But if patient has anemia, then they can occur all over. So, so we try to differentiate whether these are innocuous or they are. So this is just to say that, they can also get hemorrhages. This was a rare case. We reported this. This child had sepsis, and because of that, child had acquired protein C deficiency. So that's what sepsis does. It changes the coagulation profile, and so patients can get more severe disease. So that's why, the control of sepsis and prevention of sepsis becomes very important. And of course, sometimes we can have side effects of the treatment itself. This is some baby who had side effect of the VEGF, but usually the VEGF injections are quite safe. They do very well if they are given properly. And we are very happy with this treatment now that, in many children, we are able to give the injections if they are in critical situation, or we think that laser is not working. And so we can save a lot of retina, which we used to destroy with laser. So I want to also, just briefly tell about universalized screening, which is about the RBSK guidelines, where now WHO has also come up with guidelines for all newborns. So all newborns must undergo a basic eye checkup. Now, this is missing in our country. It is established in most of the Western worlds. A basic eye checkup. If I ask a patient at 10 days of birth, how was the eye at birth? Did somebody open the eye? Was the eye looking normal, or there was a leukocoria? They are not able to answer. There is no answer in the case sheet. There is no answer in the notes, and there is no answer with the parents. Nobody has opened. Simply just opening and peeping into the eye. Is the eye there? Is it okay? So we are not able to get this information. So simple torchlight examination of the eye by opening it and a red reflex test, this has to be done. So when we try to see which babies have to go for fundus examination and which don't, so there's a very simple triaging done. If child has prematurity, we already said ROP, they will need special screening that cannot be seen by torchlight red reflex. If there's a family history, so this is the only additional thing pediatricians and neonatologists, gynecologists have to ask, even during pregnancy and definitely at birth. Is there anybody in the family? Is there elder brother, cousin, parent who has lost an eye or had a surgery in childhood? That child needs a complete examination. In fact, they need antenatal counseling because so many eye diseases are genetic in origin. And there's so many parents come with second child blind, third child blind, and we say like, nobody told you this, and nobody told us that, this can be genetic. And, ultrasound may not pick it up. And of course, so the third is normal term baby, no family history. They can just be screened by torchlight and red reflex at this point of time. But if they are syndromic babies, you notice there's some syndrome, there are other congenital anomalies, or patients were sick, they were on, ventilator, or they were on IV cannulas, then they can get candida, they can get other infections. So we need to triage premature babies, family history, babies, syndromic and sick cases, they need a detailed eye examination, including fundoscopy. All other babies, simple torchlight and red glow. So this is just to show, if you look at the torch, you can see, just open the eyes and look at the eyes and you can make out is the eye normal or not. Another warning is about the conjunctivitis. Now in the NICU, there's so much conjunctivitis or NLD block. So it's a very, a habit of the doctors or nurses in the NICU that, oh, the child has some watering, go put some tobramycin for 1 week or go put, ciproflox for 1 week. Don't do that. You see, this child which you're seeing in the last, this child was treated as conjunctivitis for a week. And then they started noticing that conjunctivitis is not going and eye swelling. And when the child came to us, what we found was that child's eye was destroyed because of endophthalmitis from umbilical sepsis. Everything was there. So if you, notice some watering, discharge, redness of the eye, open the eye. Try to see for the glow, red glow. Try to see the cornea conjunctiva from a torchlight examination. And if there's any periorbital edema or there is something more, then please send for detailed examination. This is not simple conjunctivitis. So one should be able to know how to differentiate the common, very common conjunctivitis from an eye condition. And here is a family. All these 4 children were in a blind school. One of our social worker went to blind school and picked up this last boy who was having congenital cataract. And all these children at 9, 10 years, congenital cataract studying in blind school. That's a shame. Congenital cataract is a totally treatable condition and it can be diagnosed within 2-3 days of birth just by opening the eyes and doing a torchlight. Here we have a retinoblastoma mother. Her eye was enucleated and she's safely living nicely with an artificial eye. And nobody told her that, her child is at risk. It's a genetic disease. It can affect the next child. Her daughter, after chemotherapy, bilateral retinoblastoma, she died a few days after this photograph was taken. So, so we didn't do a good job. 40 years later, 30 years later, the mother got better treatment, the daughter did not. So red reflex is very important. These are just little older children, but small babies, we should do red glow. Just little dark room, you can put a drop of tropicamide, that makes it so easy with your cell phone camera, with your mobile camera, with any digital camera, with the ophthalmoscope, so many ways, just to see that is the red glow there or not, and is the glow equal in 2 eyes. So this child, again, these are some of the infected cases after BP shunt, got fusarium. This baby we diagnosed on routine ROP screening, white infiltrate on the retina. This is candida. It doesn't need any, test. White cotton wool deposits. And very nicely we can treat with M4B and do surgery and everything becomes okay. So, so gram-negative infections, we have published larger series of neonatal endophthalmitis. So gram-negative Klebsiella, Acinetobacter, E. coli, not uncommon. So whenever you see some periorbital edema, some redness, always open the eye and see, are we dealing with something more serious than conjunctivitis? So I'm just showing here, again, this child, just open the eye and you can see a very nice red glow. You can see cornea is clear, everything is clear. But here you can see some haze. If you see some haze, this was actually viral keratitis, HSV, or you see some white spots or something like, it'll abnormal in the eye doesn't look crystal clear, which it should in conjunctivitis. The eye should be absolutely crystal clear except for that little redness watering. Okay, so this patient we had reported was being treated as mosquito bites. This is primary herpes simplex with retinitis in both the eyes and encephalitis, which we diagnosed after we came for screening. But the mother had complained about redness, watering, and some eruptions on the face 10 days after birth. But it had been told these are mosquito bites and this is just conjunctivitis and nothing to be done. So I want to close by saying that, there's very important for all of us here to start thinking of curriculum of newborn eye health and ROP screening. This newborn eye health and ROP screening should not be neurodevelopmental chapter. It should be on chapter on critical care of newborn, on eye emergencies. And this is still not there in so many, health workers course. So both to update the competency, skills, and the knowledge of our health workers in residency, the nurses, the primary health workers, the allied ophthalmic health workers, allied child health workers, and of course the eye health leaders and all fellowship programs and CME. And again, so thankful to IMA. I sometimes think that, it's not ROP and newborn eye health is not something for pediatricians and ophthalmologists. It is for all the doctors, because, the parents and family, they ask the doctor, the family doctor, the doctor in the family, and it's the doctor in the family who will ask, oh, did you have vaccination? Oh, you have a newborn child, congratulations, when are you doing vaccination? So they should ask, when did you get eye checkup done? When is your eye checkup? That is the level at which the doctor should know. As general doctors, I know, okay, if it's a diabetic, needs eye checkup, if it's a cardiac patient, needs this, if it's a kidney patient, needs it. So same way, I should know if there's a newborn child, that child needs a basic eye checkup always. And if they are high risk, then they need a detailed fundoscopy. So we do have a hands-on training for newborn eye health and 5 days in the pediatric clinic and newborn bedside. So we train people how to do this test, and we'll be happy to demonstrate or do workshops. So, whenever you have any childcare workshop, it's a ventilatory workshop, it's a cardiac care workshop, please include a small section, half an hour or 45 minutes, give it to the ophthalmologist there, and they will demonstrate to you, how to do a basic eye checkup and how to do a ROP and, some information. So please include that, because the children are, sort of divided between the pediatricians and the ophthalmologists. So who is responsible and who takes ownership for the vision and eye? That's a question we need to ask, because babies are not in the pediatric hospital. They are in the neonatal centers. And so we have to, make plans how babies' eyes will be checked and who will check them. So the basic eye checkup should be done by the child care workers, and the detailed checkup screening will be done by the ophthalmologist. Now, very fortunate that recently we have started some new programs where we have now started training the neonatal nurses in taking photographs, and this is being done here in Fernandez Hospital. Before that, it has already been done in Nalagonda. Dr. Yadaya is here. He and his team, they learned, and now they do the screening themselves, and they pick up the disease and we treat it. And Nilofer Hospital, they have their own team, and so they are doing themselves. So I think this is the way to go forward, that the screening should be done at the bedside by the childcare team, and then they can pick up, they can teleconsult, they can send the pictures on WhatsApp or other ways, and we can do a very good job, because so many children are being saved. There are not enough ophthalmologists to go and screen all the babies all the time. So now we have all these cameras, and fortunately now we have less cost cameras, so people can pool resources. There are technicians who can, go around 5, 6, 8 centers, and they can do the photography. So that's what we are doing now in some of our rural areas, that there's a single technician who goes in the van and screens all the babies in all the centers. And, charging very nominal, 400 rupees, 500 rupees, 100 rupees. So for the screening, and then of course the money comes from the treatment. So I think, I'm so thankful to all the pediatricians. As I said, I'm not only a eye specialist, but I'm a mother of a preterm baby. So thankful to all the neonatologists, pediatricians who are saving lives. And we have shown by our polio eradication that, polio eradication happened because it was campaigned and taken up by the pediatricians. I don't think we could have eradicated polio if it was owned by neurologists and orthopedicians, because it's a neurological disease or an orthopedic disease. So same way, I think who owns my vision? I think the vision has to be owned by the newborn care facility people, and the ophthalmologists are always there to help. So I think the gaps we know, there is so good work happening in so many centers where the ROP screening is happening on time. Babies are being told properly. They are being, educated, the parents. So many times parents say that ROP screening, why didn't you go for ROP screening? Madam, wo copy mein likha hua tha. Something was written there, ROP. Nobody told us, nobody explained. We thought baby is very small. We can go after 2-3 months. Nobody told us the importance. Nobody said they can become blind. So the criticalness of the thing, the emergency nature of ROP has to be conveyed by posters, by brochures, by educating when they are in kangaroo mother care, as you saw in the video, that that this is something very critical. It can lead to blindness. When they come for follow-up, did you go for ROP care? No, this is serious. You have to go for ROP screening and get me the report. So that is what is the the emergency nature. And once they are in the care of the ophthalmologist, hopefully the ophthalmologists are well trained and they can take care. If they're not trained, then they cannot take care. So please make sure that the ophthalmologist who's screening is properly trained and knows their work. It's something which is required. So I want to conclude by saying that we are world champions when we run our own race. And here I am teaching Kho to people from Canada and USA. So same way I want to teach newborn eye care to people in other countries, because we have the largest experience in our country, both between the neonatologists and the ophthalmologists. So we can set up our guidelines, we can set up the rules, we can set up the logistics, we can have dialogues and communication and make sure that, we do quick pass between each other and then we can win the race. So our program always has kept the baby in the middle, the red glow of the baby in the middle, and we put a safety net by all the, support care and make sure that baby doesn't lose that red glow. Once they lose, there is nothing that can be done. So I just want to recapitulate what I said. Maternal health and weight gain are important. Antenatal steroids are important. Perinatal best practices, asepsis and bundle care, postnatal weight gain, express breast milk, proper oxygen management, lung therapy, anemia, judicious medication, and most important, even if we fail in all those things, even if we are not ready with all that, but timely screening for ROP can take care of most of the problems. It's the Tis Din Roshni Ke. If we miss that boat, then everything else also becomes magnified. So yes, I just want to say, मैं अकेला ही चला था जानिबे मंजिल, आप सब लोग मिलते गए, कारवां बढ़ता गया. I started all alone towards my destination, and people have kept on joining. It's almost 25 years that we've done ROP work. This is the writing of one of the stage 5 who was almost blind, is seeing little, but this is not what we want. Every baby has a right to sight, and we can have the neonatologist, ophthalmologist, ROP partnerships and make sure that they don't land into this type of place. They do really well. They can see very well. There's no need to be scared about ROP. Sometimes doctors' children get ROP and they're very scared. It's a very treatable disease, more than 90% success rate if they come on time and we are able to give good vision. So let's go. Tis Din Roshni Ke is what I want everybody to remember. And you can see here all these babies treated for ROP. This is my son here with me. He's a big boy now. And we together can really give beautiful eyes and beautiful vision to our babies in addition to the wonderful life. Thank you. I'm happy to take questions.
Thank you, ma'am. It was a very, very beautiful lecture and very useful to all the pediatricians and ophthalmologists. And you're a true inspiration, ma'am. I'm Dr. Pranusha, currently practicing at Nalgonda, Netra Eye Care. We own a NICU level 3. I'm screening the babies and also treating, ma'am. I have one baby who is stage 3 and it was in zone 3 with stage 3, but it was not continuous 6 clock hours. It was 4 clock hours. But I have waited till 44 weeks and I have lasered. Baby is doing very well. I have a doubt, ma'am. If a baby is having 44 or beyond 48 weeks or 50 weeks, if a persistent avascular retina is present, what is your call on it, ma'am?
So first of all, as I said, we have to make sure this persistent avascular retina doesn't happen. It will usually happen where all these risk factors were not taken care of in the beginning itself, from antenatal to postnatal. If we when the baby comes to us first time as ophthalmologist, or it is under care of neonatologist, if we look at these, I call it 6 Sigma checklist, anemia, weight gain, if every time we insist on that, the retina really gets vascularized fully. So this peripheral avascular retina doesn't remain there. Or if they develop some ROP and we treat it as per guidelines, then again we will not see this PAR. This PAR happens where there is suboptimal care, or we just allowed the disease to go away like stage 2 and we don't treat it, and then this PAR remains. Now there's controversy of how to treat it. So there are some people who feel that PAR. Now PAR has been described in the new ROP classification as two disc diameters of avascular retina. Two disc diameters, which means it's a large area, not just a tiny strip. So what I see, many people are very worried. There's little bit of avascular and they start saying PAR, PAR, PAR. No, the PAR is the new terminology. It has been described as two disc diameters of peripheral avascular retina or posterior avascular retina. That's the classic definition which has been given. And it is called as persistent avascular retina, which they describe as two disc diameters. So first of all, we should be sure that it is two disc diameters and it is not some tiny bit. Tiny bit, it can be left alone. Now, two disc diameters, people are thinking that this will cause lattice degeneration later in life or detachment. It should be treated. So, depending on individual baby, we decide to treat. There is no emergency to treat. It can be treated at 6 months, 8 months, because the lattice and holes don't come immediately. So what I do is I just wait, and when the baby is little older, then I take up under GA and do proper laser. We can do early also, but why to do that early? I think just give time for the retina to develop, take care of the systemic factors. Many times children has been referred to me for treatment. I treat them with a systemic therapy, medical treatment, and then, they only few of them later need treatment. But yeah, if patient is not going to come for follow-up, which happens, then we take a call and we treat it.
Then if a peripheral avascular retina with a few vascular anomalies, ma'am?
Yeah, we'll treat it. We'll treat it. Yeah. But as I said, we can choose the timing depending on dialogue with the parents, what type of health is there, what type of family is there. We can select. If we think that, they cannot afford GA later, or child has cardiac problem or something and we can't give GA later, we'll go ahead and do under topical before they are 2.5 kg. But if we think that is healthy, we can do later under GA at 6-8 months.
Okay. In a case of anti-VEGF treated baby, you are repeating it. If it is a reactivation, you will be repeating the injection, ma'am, or you're going with the laser.
Yeah. So again, take all the factors into consideration. So we have some children, and we're just publishing the data where somebody has given injection and baby comes to us at 2 weeks or 3 weeks, and we see it is still active. That means the injection didn't work. So either because these injections need cold chain. So maybe the cold chain was not maintained and it was an inactive injection, or maybe they injected and it extravasated, it didn't go in, or maybe the health of the baby was not taken care of, just injection was given and the other factors were not considered. In those babies, I will give another injection because I can see the first injection was not of use. So I can. Now, if we have given the injection, disease went off well, and then it recurred at 45 weeks. Again, we have published the data. It recurs mostly when we have not taken care of systemic therapy, or we have not given bevacizumab. Meta-analysis shows that bevacizumab, that is Avastin or Zybev, they have less than 10% recurrence, and their PAR is also less. Whereas Razumab, which has been now approved by many governments in India, that is ranibizumab, which is the approved drug, it has 40% recurrence.
Yes.
And Eylea now has about 60 to 70% recurrence. So depending on what drug is used, what dose is used, so that's why I use Avastin only, although it is off-label. I can go to jail, I can be killed for that, but it is the best for the baby. The best, all over the world, meta-analysis data has shown that it's the bevacizumab, which is the most effective, and it is quite safe, and it has the least recurrence rate. Now, if recurrence occurs, yes, in many babies, I will repeat the injection. In few babies, if the recurrence is along with fibrosis, then I will do laser.
Along with fibrosis.
And in some babies, after second injection, again, if it still doesn't go, we'll do laser. So what I want to say is that, as doctors, we have all the armamentarium with us. Which bullet we will fire should be based on our deep understanding of what it is doing. So Avastin, okay, it will lead to delayed vascularization, but it will take care of all the VEGF which is secreted, but it doesn't stop new VEGF from secreting. Laser does that, but then laser destroys the retina.
Destroys.
And laser can cause more myopia. Even anti-VEGF injection will cause more myopia. So we should not say that we are giving injection to avoid glasses. That's a myth. On the first day only, I tell all preterm parents, your child will need glasses so that they are not disappointed later. Because preterm babies need glasses, whether they get ROP, they don't get ROP, and whether they undergo surgery or injection or lasers, they are at very high risk for ROP, for myopia. Okay, so myopia is part and parcel of preterm delivery. So never promise parents that, they will not get glasses. Yes, glasses are highest after surgery, little less after laser, little less after injection, little less for those babies who got mild ROP, and the least for those who never got ROP. Okay, but it's not that they are free of glasses. Even not normal babies are getting glasses. Even term babies can get glasses more and more. I see so many parents, the moment babies 3, 4, 6 months old, Cerelac started, mobile also started. Baby is 1 month old, video call with grandparents starts. Every evening they have to do half an hour video call with grandparents, with Masi, with uncle. It's a very bad strategy. I think all of us, you are here listening to me, please discourage parents from using mobile, video calls, TV. This is really causing a huge myopia epidemic in all children. And then these children just get hooked to that. They don't listen anything. They only want mobile. When they are feeding, we should feed them the way we were fed. When I was fed by my grandmother, it is stories, it is Kawa Agya, it is, Bhoot Agya, so many stories, Mahabharat, Ramayan, Bible, whatever. It is the time to bond with stories and communication, not time to just give that phone and make person to eat something and push down their throat. I think all of you, please, because you're pediatricians here, doctors, please give that advice to parents that children will get hooked to mobile devices. It is awful for their speech, for their cognition, for their vision, for glasses. It doesn't provide any development to the child.
वाली किसने खानी है?
Madam,
Ma'am, we have a sorry, ma'am, we have a question in the chat box. What extra precautions should be taken in ROP babies who have undergone blood transfusion and have worsening of ROP stage?
Yeah. So see, these are two things we are tackling. One, we are tackling the underlying fuel. Okay, suppose you have a fire, always say ROP is like a fire. So you will take care of removing the fuel, right? And you will also look at extinguishing that fire with your fire extinguisher. Both things have to go side by side, right? So the fuel is the anemia. The fuel is the sepsis. So if there is anemia, please give the transfusion. Okay, make sure that hemoglobin is always 10. Now, even if we remove the fuel, the disease may be of such a tempo that there are other factors, genetic factors, or patient had received a lot of oxygen. So as it worsens, we have to treat. We have to treat with laser, surgery, injections, whatever. We have to put out that fire. But if we don't take care of the fuel, then fire will become more worse. So both things have to be done together. The systemic factors, and now ROP screening treatment by laser is available, yes.
Madam, I have one small doubt, madam.
Bully, sir.
So how do you decide between the choice of anti-VEGF versus laser?
So currently there are some guidelines about which babies to inject. So usually more posterior disease, aggressive disease. Then we also have described in literature and others have described something called atypical ROP. So these are children who come with exudative detachments. They come with bleb-like detachments. And children who are sick, children whose pupil doesn't dilate for us to do laser, children who are still unstable and, they cannot take the laser because laser takes 2-3 hours and it is little more stressful. So babies who are still on ventilator and somebody is not competent to do laser. In some remote areas, laser is not available. There's nobody to give laser. So there are various indications why we give injections. There are some concerns about injection because they can have side effects. Most important is, if the injection is not given properly, they can get endophthalmitis, which can lead to loss of eye. Fortunately, risk is very, very low. proper asepsis, it's very low, but it is a real risk. It's like a surgical procedure. And then cataract, if the trained people don't give, then sometimes cataract can develop. So cataract in a newborn baby, again, leads to poor vision later in life. Although we do the cataract surgery, but still they have problems because we can't put intraocular lens at that age. So these are two side effects. There are concerns whether it will cause any systemic side effects. Lot of data, no good prospective high quality data still there. I have been using for almost 20 years now. I don't see any high, cognition deficit or motor deficit or anything. But yes, still robust data is required. But I think the dose we are giving is 0.025. And it remains in the blood for a long time, but I don't think that it is really causing any major issue. We still keep a eye on that. We are continually collecting data. Are the babies showing any serious problem? We have not found that in terms of the development and all. Most of these children are doing quite well. So, but we don't want indiscriminate use. If it is an anterior disease, it's a milder disease which needs treatment. Laser is single session, single treatment, doesn't get a recurrence. Recurrence rate is less than 2% if laser is properly done. I told for injections, it can vary from 10% to 50% depending on what injection is given. The laser is good in the sense if parents miss some follow-up, it can still take care. But if in injection they miss follow-up, the disease can come back with a bang, and really recurrences can be very, very bad. So I think the dialogue with parents and understanding diseases and their guidelines. And if we stretch the guideline, that is true for any disease. If we stretch the guideline, we should document why we have stretched it. We should document why a particular treatment is being given. That is good clinical practice for any doctor for any treatment. There's treatment A, there's treatment B. Read about it, learn about it, become master of that disease or technique. Then we are master. Then we can decide what is best for a patient. Guidelines are guidelines, but how you deliver it to a given patient, that is the skill of doctor. There is no robot or AI which is going to replace the mind of the doctors, because they understand that individual patient, they understand the drug, they understand what it is doing, not doing, and they can, discuss with the parents and give them the best options. But yes, guidelines are there where we have to inject, and Indian guidelines are also regularly coming out. We keep on updating it. So, just be updated on that.
Should be given by an adequately trained person, you mean to say.
Yeah, anything, even if we have to put an IV line, it should be a trained person, no?
Yes.
People should self-regulate themselves. What I'm capable of, what I should do. Take proper training. It takes, when I went for training for 3 months, somebody can go for 2 weeks, 1 month, depending on your pre-existing skills. But don't do things for which you're not trained or for which you're not skilled. Some training we should take.
Thank you, madam.
Madam, good evening.
Yes. Yeah, here is Dr. Chandu, madam.
Madam.
He is ROP Nalgonda. And please help me to be able to screen around 6,000 babies in our unit. Please speak, Chandu.
Hello.
Hello.
Hello. Madam, good evening, madam. This is Dr. Chandu.
Namaste, sir. Cheppandi.
Madam, namaste. So, madam, one question. In APROP, how many weeks we should do the follow-up after treatment? Hello.
The American Academy guideline says about 6 weeks. So, but what it also says is that we have to follow till the whole retina is mature, and or vascularized. The new terminology is vascularized and non-vascularized. They don't say mature, immature now. So that the retina should be completely vascularized, and the debate still goes on. If there is a peripherally vascular retina, preferably before 63 weeks, it should be treated.
Madam, which is the best treatment for APROP?
So for APROP, current guideline says injection.
Injection only.
Yes, bevacizumab is the best. Now, if for some reason, sometimes we are not able to give injection. Let's say child has conjunctivitis, adenoviral conjunctivitis, or child has NLD block, okay, or we are not able to give that injection, maybe it is not available, cold chain is not available, then we should go ahead and do laser. So there are specific indications where we can't give an injection.
Which laser is, madam? Laser or green laser?
Say that again.
Which laser is better? Diode or
the green laser is good. Now data has shown that green laser is better because it is very soft, it has less pain, and it is usually available for adults also. So previously it was advocated red laser, but now data has shown that trained people, there is no difference between green and red. So green being less painful, then that is the laser now we all use. We've all shifted to green.
We have 2 more questions in the chat box, ma'am. After anti-VEGF, how long we can wait to give lasers or other injection if child ROP is not progressing?
Yeah, so we can keep on waiting indefinitely. So the guideline says, by 63 weeks or 60 weeks or so, you start deciding what you want to do. You want to give more injection, but more injection you will give only if the disease is active. If it is just halted, it is just arrested, you have to make a decision. Will you treat now or you will treat in 2-3 months if the baby is coming for follow-up? As I said, these questions arise more when the systemic therapy has not been taken care of. If you take care of the systemic therapy, you will see less and less such decisions to be made. Okay, so there is no hard and fast rule. We have to see that the disease doesn't come back. The peripheral avascular retina is taken care of either by observation or by treatment. Okay, and the thing is that if we don't treat it, then our follow-up is not complete. We have to keep on following every 2 months, 3 months, 4 months, because these areas may develop problem in 2 years. Even people have shown after 5 years, they will have these new vessels in the periphery, which is a risk factor for late onset hemorrhages or late onset detachments. So we have to treat at some point of time. We can't just leave it alone. It is a fuel which is there. It will cause some problem later in life. The timing you can decide.
How many injection?
If a notch is extending to zone 2 posterior, should we laser or give anti-VEGF? If we laser, it is going to be quite posterior. One more question in the chat box.
So see, these injections came only last 10-15 years. Before that, we are doing lasers and we showed 80 to 90% recovery with lasers. So if you think that, there is plus disease, it's very hot, the pupil is not dilating, there's a posterior ridge and there's no fibrosis, you can go ahead and give injection. That notch will get closed, the retina will grow, then periphery you can laser. But suppose already there is traction, already there is some reason why you can't give injection, then you do laser. And you can do posterior laser. Yes, they will get little more myopia. But see, that is the safe treatment at that point of time. If child has NLD block, you can't inject. Right? Then what will you do? But yeah, if there's a posterior notch and you think this is very active, then you go ahead and inject and then do the laser after a few weeks or days or months.
What are the current
more injections we are giving? Yeah, for more posterior disease. Precisely for that reason only we are giving injections so that we can save the posterior retina more.
What are the current guidelines for lasers for recurrence? Should we do if see early signs of recurrence or wait for plus disease?
I think what happens is if we have injected an eye, the plus disease doesn't always show up easily. The vessels permanently become very tiny. It's very difficult to pick up recurrences. In fact, Min Sitna, who did the beta ROP study, she says do FFA. So they are doing FFA in all babies for follow-up to decide is there recurrence or not. So clinically, the recurrence may not be easily visible. So even if it looks there's no plus, but there is a recurrence, we are seeing new vessels, I think it makes sense to treat because the disease has come back, right? So if it has come back, and especially for those babies who are systemically unstable and it is still in zone 2 posterior or zone 2, I think we should treat either with laser or repeat injection. Okay, I don't think we should wait. Few babies, if it is just stage 1 and there is no plus and otherwise baby is doing very well, then I follow in 1 or 2 weeks and make a decision. If it's still becoming okay and then I start seeing that vessels are crossing that line and it's growing and we have taken care of the systemic thing, some of them regress on their own also. The only thing I want to say is that after having experience of so many years in ROP, once the injections came, it took me at least 4 or 5 years to start understanding the disease after an injection. So I have to relearn ROP. You know, how it will behave, how the injections, what they are doing, what is recurrence. So Dr. Tapas has given beautiful cartoons. His publication is there on serial examination of the retina after injection. So he has shown that the retina starts getting sawtooth vessels, and this is a good sign. And then they can get some looping, and that can look like a recurrence, but that's not recurrence, that's remodeling of the vessels, and then they grow normally. Okay, so people who are giving injections should learn. But what many people do, they give injection and then they say, "Go now, madam will follow." Don't do that. Okay, give injection, learn how it looks like, train yourself, see these patients every week, 2 weeks, then you will learn, you will understand what is a recurrence, what is a sawtooth vessel, what's a tungsten vessel, what is a circumferential vessel. So all this has been described now in literature, that the retina becomes different after we give an injection, and we have to learn about that. So we will learn, we all will.
Ma'am, 3 more questions in the chat box. A baby not treated with anti-VEGF still having stage 2, zone 2 after 40 weeks. Should we laser the persistent avascular retina or follow up? Which is already answered, I guess.
Yes, I think we should laser. We should not leave it like that. They become bigger. It's difficult to follow. So unless we are in a place like ours where we give GA left and right, I think if we see it and we see that the retina is still not growing, and it has just arrested and there's some stage still continuing, it's not 40 weeks. The people are describing up to 60 weeks also we can follow. And parents are willing to follow. We can even wait till 50 to 60 weeks. Okay, what's the
Ma'am, any special ROP referral form to send ROP child from rural hospitals?
So I don't know, this is for our hospital, for any hospital. I think most important thing is, which sometimes we don't get, is all the information about the baby. The discharge summary, what was given, what was the course. Because see, what happened to the baby before ROP and after ROP, that tells us what is going to be the tempo of the disease. What is going to be, so how many risk factors were there? If I see stage 1 and I know baby is still on oxygen or still desaturating, then I know it will become stage 2 and 3. But if it is mentioned this was the weight initially and now this is the condition, or this baby didn't require oxygen or required, then I know, okay, baby may not get very severe disease. So that information, the pediatrician's information, is very, very critical for us. Whatever has been done, that should be accompanying the child. And if the child is critical, on critical care, coming on oxygen or ambulance, then, you know, somebody need to accompany. And in my hospital, we have a special NICU. So if that type of baby comes, they should inform at the reception, then we shift to, it's called room 307. So there's no special form. I think just like you refer everybody. For our hospital, we are now taking care of these ROP babies 24/7. Our emergency team is there. They are able to handle babies. But just don't tell them to meet Dr. Subhadra. Just say go to LV Prasad and the ROP team will look after you. Because sometimes they wait for me to be around. I'm not there 24/7, but our team, hands-on team who know photography, who know ROP, who know injection, who know lasers, all the doctors are there. At least 20 doctors are there.
One more interesting question, ma'am. If we have islands of stage posterior to the major vascular ridge, should we laser the avascular island also, or laser only avascular retina which is anterior to the major ridge?
All avascular retina has to be treated because it's the avascular retina which spews this VEGF and all other cytokines also. So yes, I burnt my fingers once because this was not explicitly mentioned in the books, especially if they are posterior islands of avascular retina. This is AROP. That is why the retina has grown and it is left eyelets behind. Even as I said, anti-VEGF, they have shown after recurrence in anti-VEGF, they are posterior islands of avascularity. If you don't treat that, so the current ICROP classification also says PAR is including posterior vascular pockets. They have to be lasered. They have to be taken cognizance of. So never ever leave them. So now recently, very nice, just for everybody's information, we have just started oral fluorescein on adult camera for our babies. It does very well. The data and the methodology is already there in literature from other centers. So, so if you want to really do an FFA, and it's safe, it doesn't have any anaphylaxis, it's oral mixed in bottle milk or mother's milk. You can just give those a few drops and then take the photos after 15-20 minutes, half an hour. Good fluorescein comes. So by chance, if you want to do fluorescein. But yes, These babies, they need laser if there is posterior avascular retina. All avascular retina should be treated. Even for stage ROP, if there's sometimes babies come late, the retina grows, it leaves pockets of avascular retina behind, posterior to the ridge. That must be treated.
Any more questions, please?
Madam, any role of steroids in the intravitreal?
So there are a couple of people who have talked about intravitreal steroid. I have never used that. But yes, we have done a lot of studies on the vitreous of these babies whom we operate, and we have very good publications which is hailed worldwide, where we have shown that there's a lot of inflammation, and that is what causes the haze. So there's complement activation, there's MMP9. So one of the things that I have learned from those basic science studies is that when you're following the babies, if the media is hazy, means that the disease is still smoldering. Never ever release a baby if you don't see crystal clear each retinal vessel clearly. Okay, that is the mistake many people have done. They think retina is vascularized, or they give injection, or they have done laser and they say it is regressing, then it is regressing, it is regressing. No, it's not regressing, it is smoldering. So if the inflammation is there, the pupil will not dilate fully, the media will not be crystal clear, you will not be able to follow each vessel individually. These are signs of inflammation, and that shows disease smoldering, and it has to be treated with laser, anti-VEGF, systemic therapy, whatever. I have not given steroids in the eye. There are a couple of doctors who have reported, but it's not a routine practice.
Madam, in case of hazy cornea, hazy media, how can we see the ROP? Is there any other methods?
So we have published a series of cases of congenital glaucoma and ROP. And what we used was the pupil dilatation. When there is no ROP, the pupil dilates completely, fully 8 to 9 millimeters just by 1 or 2 doses of the dilating drops. Now, if pupil is not dilating and you see in the congenital cataract or glaucoma, or of course, if you see NVI, but if you see pupil is just not dilating, then we presume there is ROP behind. We inject till we are able to clear the media by glaucoma surgery or cataract surgery or whatever. It tides over those 6 to 8 weeks, and then we examine the retina as soon as the media clears. So that is what we have published for congenital glaucoma or other media haze. Sometimes the media very early, if we examine these babies 1 or 2 weeks of birth, the media can be hazy. This is because of hypoglycemia or hyperglycemia and certain metabolic acidosis and all which these babies are going into. So if we just wait for a week, the media clears, and then we can see. But pupil dilatation we can use as a surrogate measure of what is happening behind.
Okay, thank you. Thank you, madam.
Thank you, madam. Thank you so much.
Sir, one more question is there in the chat box, sir. Medico-legal issues of using Avastin in ROP, ma'am, for private practitioners.
So we have talked to a lot of lawyers, legal people. We should all know what is the legal standing. So the first thing is that in our country, off-label use has not been talked about. So, if somebody starts questioning why you have given Avastin, then you have to find out in endophthalmitis, you cannot give vancomycin. That is off-label. It is not a drug made for the eye. Then you cannot treat any endof in this country. Okay. So same way, ringer lactate, it is not approved for use in the eye. It clearly says this is for intravenous use. Left and right we are using, right? So important thing is for Avastin, there is no medical legal issue. You have to take proper consent, inform the parents. So the AIUS website already has a consent for Avastin in other diseases. It is not for ROP. You have to add that ROP there. And that is the consent the VRSI and the AIUS has approved for use of Avastin in normal people. If anybody wants, we have the consent form. We can send it across. So that is one thing, to have the consent, proper consent. That's for everything, including Avastin. If you want to defend yourself, what the court will ask, what are the practitioners in the world doing? All the ASRS, Asia Pacific region, India region, there are so many surveys, which is the drug you are using in retinal disorders. Everywhere it says Avastin, most people are using, eccentrics, Eylea, others are using. If you go to literature, beat ROP study, it was done with Avastin. Okay, so you have literature supporting you. If you see number of articles on Avastin in ROP, everybody in the world is using. From India also, so many publications are there. So you can always defend yourself, but you cannot defend if you have not taken proper consent, which mentions this is off-label use. We are using it because it has the best outcome, and there are side effects like any other thing. So the proper written informed consent, if you have and you have talked to the parents, there should not be any medical legal issue.
Thank you so much, ma'am.
And the book you have suggested, that is very nice book, madam. JP. Hello?
Yes, yes.
That book you have suggested, madam.
Yes. So the RBSK guidelines are there, and now on the WHO website, you can also find the WHO CRO neonatal screening guidelines. So WHO recently put eye screening, ENT screening, and thyroid screening guidelines. I'm happy that I was also part of that. It has a video and it has again the pictures and the triaging. So please use that to screen all the newborns in addition to the ROP. That is also made similarly for health workers in very simple language.
So thank you, madam. I think there are no more questions now.
Thank you,
Any more
everyone.
questions? Madam, thank you,
That's
madam.
it, sir. I cannot see anything in the chat box.
Yeah. I now request Dr. G. Sampath, our convener, Scientific Committee, Telangana IMA.
I need 1 minute time, madam.
Yeah.
Madam, this is Subhadra Jalali. Thank you, madam. We are very grateful to you. And if we're able to screen almost more than 5,000 babies with your help, and our neonatal ROP prevalence rate is 10 to 15%. And we have taken interventions to prevent the ROP. And we have blended oxygen since the last 6 months. And we have low flow meters. And we are doing red reflex for all the babies admitted to the unit, madam.
So somebody has written, can we get all slides? So just to inform, almost all my talks are on YouTube, on AIO's website. If you just Google search, most of this material in video form, slide form, everything is there. There is no issue.
Today's program also will be there, madam.
Yes.
Yeah. I now request Dr. G. Sampath, our convener, IMA Scientific Committee Telangana, to convey a vote of thanks on behalf of IMA.
Very heartful thanks to Dr. Subhadra madam for giving an excellent lecture with her vast experience. It's a very important topic, and many of our doctors may be ignoring this particular thing, but she has, with her vast experience, and she has correctly mentioned that in our country, with the huge population, probably we may be having the highest burden of this particular ROP. And she has given a clear indication about the prevention and the precautions to be taken and the antenatal use of steroids. Plus, most importantly, the simple test immediately after birth, a simple torch test to test the vision of the newborn. And she has also given a very clear discussion. She has led a discussion about the treatment modalities, the laser treatment, other treatments, and the follow-up to be done. And she has given a few instances where probably the children, the newborn, were not screened on time, and then they had to lose their vision. So this is a very, very important topic. And she has also very correctly mentioned that in the newer guidelines, the screening has been included, and probably all doctors should be aware of this screening and also the treatment modalities, and they have to refer to the correct center on time for treatment. Of course, prevention is the most important aspect. Thank you very much, Dr. Subhadra madam, for giving a very good lecture and sharing your vast experience. And I thank all the participants also for I think we had almost 70 participants or more than that who have listened to what madam has told. And more importantly, we had more than half an hour of discussion after the lecture. So this only indicates the interest it has been generated by the talk. And madam has given very good and clear answers to all the queries which have been raised. So thank you very much, madam.
Thank you so much. And,
thank you, madam. Thank you so much.
Thank you so much, everyone. I just want to close by saying I committed a mistake once. I wrote to the patient, come on 7/6/2024, let's say, example, 7/6/2022 or something. And the patient came on 6 July. They didn't come on 7 June. And I asked, you were asked to, and by the time child's eye was very bad. So they came 1 month late. I said, why did you come 1 month late? I have very clearly written 7 June. So he said, oh, sorry, madam, I live in Dubai. And we read the dates in the, USA style. So I learned my lesson, that clear information is very, very important. So now I never write 7/6/6/7. I always write 7th June, June. So same way, I think all of us should learn the communication, the writing. Somebody wrote, ROP screening on Thursday. This was in Mumbai, educated family. They went after 2 months. They said it was not mentioned this Thursday. We thought we can go on any Thursday after any number of weeks. So please mention it clearly, critically, put the posters in your NICU area so that miscommunication is not there. Thank you so much. It was a wonderful